Good afternoon, everyone. Welcome back to Epilepsy Awareness Day. You're at the VA Epilepsy Centers of Excellence program. Our next speaker is Dr. David Naylor. He'll be speaking on epilepsy diagnosis and treatment decisions. Go ahead, Dr. Naylor.
Okay, thank you very much. So I wanted to make this talk a practical talk on basically a patient who presents with a new seizure, what sort of thinking we engage in to both the diagnosis, either as a seizure or as epilepsy. And then once we make an appropriate diagnosis, how do we decide on our management plans and inform the patient on our thinking? So first of all, when you encounter a patient who has had a transient episode lasting seconds or minutes, maybe even several minutes, you want to discern, is this a seizure or is this something else? So I will go over some of the considerations of alternate disorders that this could be. If we do decide that this is a seizure in likelihood, was it provoked or was it an unprovoked event, in which case it might meet the criteria for diagnosis as an epilepsy. And in addition, we want to also clarify what sort of evaluation we do to characterize whether it's epilepsy and what type of epilepsy it is. And finally, there are many new management options for epilepsy that go beyond anti-seizure medications. And so how do we choose the appropriate seizure medication? And if these seizure medications are insufficient to control the epilepsy, what alternatives do we have? So first, is it a seizure? Well, these are transient events, and very often the doctor can't witness these events. Fortunately now, many people have videos available on their phone, so that is very helpful if we're able to capture one of these events and show the physician. But we really have to rely on the history that's provided, the details, what the patient does, for how long. And so it's really dependent upon the quality of the information that's provided to us. And you should keep in mind that all shaking movements are not seizures. There are many sleep disorders that can have limb movements that can easily be confused as a seizure. And then also, not all seizures are epilepsy. It may be a one-time event that is unlikely to occur once the precipitating situation is removed. So other considerations for besides being a seizure are, one, syncope. This is commonly felt to be one of the key distinctions to diagnosis. Is it syncope or is it a seizure? Syncope has very different features. Often it occurs while standing. The blood can pool in the legs and you get insufficient flow to the brain. And you can lose awareness briefly as you fall, and then reperfusion of blood to the brain is reestablished. But up to 25% of cases of syncope can have some convulsive movements. The brain is not getting enough blood, and there can be some associated convulsions with this. They're usually very brief and not characteristic of a typical seizure, but there can be movements, especially if someone bystander is trying to help the patient back up and the perfusion of the brain is not reestablished. There are other disorders during sleep. REM behavior, where people enact their dreams, can be quite violent, and patients can actually injure themselves during these. There are periodic limb movements. There can be frequent arousals that can be also involve a lot of aggressive type behavior and shaking with obstructive sleep apnea. While a patient is awake, there are certain psychiatric disorders, panic attacks. These often last much longer than a seizure, 10 minutes or more. and they have characteristic features of impending doom and often in public. So they have some features that may be similar to seizures, but many that are distinct as well. Hyperventilation can cause lightheadedness and decreased cerebral perfusion. So if someone is anxious or hyperventilating, that may also be similar to a seizure. There are movement disorders, tremor, myoclonic jerks. If a patient has some metabolic derangements, say they're diabetic and taking insulin, their blood sugars may drop too low. If they have other infections or toxic metabolic derangements of their electrolytes, that also can cause alterations that can either precipitate a seizure or can look like a seizure. So it is important, as I said, you often, the physician can't witness the details, so history provided by the patient is crucial. Noting particular triggers, sleep deprivation, other medication use or drug use, what the temporal pattern was, the evolution of the event described by a witness if the patient is altered. Was there a loss of awareness? How long was this? Sometimes you can estimate the duration by what the patient remembers first after the event. If the paramedics have arrived, and it was obviously probably a much longer event of several minutes. If they recall quickly thereafter, it may have been a very brief loss of awareness, as occurs with syncope. There may be some focal features during the seizure, such as looking to one side, fumbling or moving hands, and lip smacking, or automatisms that may occur during a seizure. There may have been a warning and an aura. This can be epigastric, a displeasant smell or taste. There can be fear, deja vu. And then it's also important to note what is occurring after the seizure. Is the patient weak on one side? Is the face weak? Is there decreased blinking on one side? These can all be clues as to, is this a seizure? And if so, does it lateralize to one side of the brain or the other? And also important is if there are more than one episode, how are they from one to the other? Are they stereotypical? In other words, they have very similar features from one to the other, or are they quite different and variable on each occasion, both in terms of the appearance and the duration? And then other features such as incontinence, tongue biting, should also be noted. So a seizure duration typically is a minute and a half or so. The key features are a tonic period that lasts approximately 20 seconds, and then this can be followed by a clonic period that is 40 seconds or more, up to a minute and a half. And so the total duration of a seizure is approximately a minute and a half to a little over 2 minutes. And this is a fairly consistent phenomenon. It's upwards of 5 minutes, that's 2 standard deviations beyond the typical duration. So either that would be recurrent seizures or that would be some other phenomena. So the time and duration can give you clues as to what the event is. A typical generalized tonic clonic seizure involves a tonic phase. If the patient is walking, they'll stiffen up, they'll straighten out, straighten their arms. They may forcibly force air out of their lungs and have an ictal cry. With the stiffening, they will fall, often can be propelled backwards, and can hit the head. During the clonic phase, the 3 hertz, 3 per second movements occur, and these may slow down over the course of 40 to 60 minutes. And then after that, you'll enter a postictal period that can last 10, 20 minutes or so. The clonic phase, you'll often have tongue binding. This is often on the side. And during the postictal period, you have this profound relaxation where incontinence generally occurs, and the patient will be altered during that period, lasting 10 to 20 minutes. And this postictal period is felt to be the profound inhibition of the brain that was able to stop the seizure. So physical exams and labs that we do when we encounter an episode, and to try to clarify exactly what happened. Tongue biting is usually on the sides. We can assess postictal Todd's phenomena. So there's often this profound inhibition, particularly on the area where the seizure started. So if you have a loss of vision on one field, one side versus the other, that may give a clue. If a person is unable to speak, that may give a clue as to the lateralization as well, if they're weak on one side, so on. Generalized tonic-clonic seizure can be fairly violent, so we may measure creatinine phosphokinase, which is a breakdown of muscle that can often be elevated with motor convulsions. We'll check electrolytes, anti-seizure levels if we're unaware of the patient, to get a clue if they are on a seizure medication, and if so, is it therapeutic? Do a tox screen. And then additional workup either at the time or after. It can be very informative. If you're able to obtain an EEG at the time, you may determine interictal activity. That certainly would help you make the diagnosis, because that's highly sensitive and specific for a seizure, and particularly an epileptic seizure. And then if you catch after the seizure, you can see some postictal slowing that also may be lateralized and be informative as to the site of a seizure. So single seizure versus epilepsy. So one, in the history, you can gauge what the risk for having a seizure is based on past head trauma, if there were febrile seizures as a child, if there was birth trauma, if there's a family history. And in older patients, stroke and neurodegenerative disorders such as Alzheimer's are more associated with late onset of epilepsy. You'll ask if there are other episodes that may not have been recognized as epilepsy. This may be the first generalized tonic-clonic seizure that was brought to attention because it stands out in particular, but there may have been other events at night with tongue biting and incontinence. There may have been auras or warnings that the patient did not think much of, funny taste, smell, epigastric rising. There may have been lapses or staring episodes where the patient drift off, and these may be associated with frequent vehicle accidents or other accidents such as burns that may give you clues that there were seizures that occurred before the one that was brought a patient to your attention. So there should also be some exploration of provoked contributions to the event, medications, new medications, some in particular are associated with convulsions, including bupropion, clozapine. There may be metabolic derangements also possible. If a patient was sleep deprived, that should be known. If there's substance abuse, and we'll check for a tox screen often. So alcohol use, all these things can be contributed to a provoked episode. So what is the cause? And this is key for assessing a new seizure. Because the cause may be something that you need to be aware of and address rather urgently, particularly a mass in the brain. So considerations of etiologies include genetic, often referred to as idiopathic or primary. There can be cortical dysplasias or migration abnormalities. So during development, neurons will migrate, and if there is some abnormality in where they go, there can be an accumulation of neurons in places where they shouldn't be that can lead to seizures. There is mesial temporal sclerosis, which is some inflammatory change in the mesial hippocampal areas that is commonly associated with some of the more refractory causes of epilepsy. And while we don't know the exact cause, there's increasing evidence indicating that prolonged febrile seizures may be contributory to the development of this later in life. Degenerative disorders such as Alzheimer's, I mentioned, it's estimated that 10% have seizures, but there may be many seizures that we're finding in patients. And this is, again, an active area of exploration where we're not aware of the seizures, and they may actually be contributory to some of the pathology. That's an active area of investigation. Tumors, masses, arteriovenous malformations, trauma can contribute to epilepsy. Stroke, intracranial hemorrhage, 20% of strokes can be associated with epilepsy, particular cardioembolic strokes, hypoxic injuries to the brain associated with epilepsy, as well as infection. And I mentioned some of the toxic medications. So by age, we can see that as you get older, you're at increased risk for cardiovascular disease, CVD, the blank box, and then neurodegenerative disorders with the slashes. And then early in development, those are obviously the young developmental disorders tend to be in the younger, and trauma is sort of in the middle, and the high risk periods where young males in particular taking risks and driving accidents, these sorts of things. So the epidemiology of epilepsy, up to 5–10% of the population will have a seizure during their lifetime, and yet only a half to 1% of the population carries the diagnosis. So clearly, there are many people who just have a single seizure and not have epilepsy. And so it's important to recognize these and not to engage in treatments that are unnecessary. The risks we already discussed that should be probed. There are some injuries to the brain that are particularly prone to cause epilepsy. These include trauma, which can, if it's penetrating, can cause epilepsy up to 50% of the time. Depressed skull fractures, 10%. So a minor injury hitting your head without loss of awareness is probably unlikely to be contributory to the epilepsy. And usually it has to be pretty significant head injury with loss of awareness of beyond 2 hours that is most likely going to increase the risk. Brain abscesses are highly associated with epilepsy, again, similar to penetrating injuries. And then I mentioned the relation of prolonged febrile seizures as a child with mesial temporal sclerosis. So now there are two broad seizure classifications, and these are divided primarily between focal onset, which start at a particular area of the brain and then may or may not spread. And if they spread to the contralateral side, there'll be a loss of awareness, and then that can also progress to bilateral motor convulsions. And then another classification is generalized at onset, and this may be both non-motor, as in childhood absence, where you just have staring spells, and then there can be generalized motor convulsions, tonic, clonic, tonic, and so on. So those are the two broad classifications that that we discriminate as clinicians, and that we're trying when we see a patient, that we're trying to discern, because the treatments will be very different, and you have to look hard for a focal epilepsy. You have to look hard for the cause. For generalized, those are often genetic. And so you don't have to look for a symptomatic cause that might be addressed, such as a tumor. As far as focal, there are focal aware and then focal with impaired awareness. The new nomenclature replacing the prior terms of simple versus complex involving a loss of awareness, and that implies bilateral spread. And then that, as I said, can go on to a generalized tonic-clonic seizure. And if you only know that someone had a generalized tonic-clonic seizure, you may have a hard time telling if this is a primary generalized tonic-clonic seizure, or if this was secondary evolving from a focal onset. And again, it can be key to distinguishing that, and part of the workup with EEG and taking a careful history to assess if there is an aura, which implies a focal onset, can be key in distinguishing these two types of seizures. So a focal lesion with focal onset here, it doesn't take a glaring change. This is an MRI scan, and the right side of the brain is on the left side of the screen here. This is the right temporal lobe and the left temporal lobe, and this is what's called an axial cut. And then this is a coronal cut that is perpendicular to these two cuts are perpendicular. Anyways, this is the hippocampus, and you'll note that it is smaller on the right side. Again, right is on the left side of this image here. And this structure is smaller than this structure. So this is a sclerotic hippocampus that we can assess mesial temporal sclerosis by what are known as signal changes on MRI, changes in how the hippocampus looks, as well as volume loss types of changes. And so there's an abnormality, and it can be subtle to the uninitiated, but for a focal onset epilepsy, a small area of the brain that is abnormal can recruit otherwise normal healthy brain, and then that's what causes the seizure. And so often during a workup, particularly in patients who do not respond to medications, we'll want to find that small circumscribed area of the brain that might be able to be addressed by surgical or other interventions to prevent it from triggering a seizure and taking over, commandeering the rest of the brain. So basic seizure mechanisms and mechanisms of propagation. The idea is that with an injury, that there is some rewiring of a network, and seizures themselves can also contribute to injury. So there's some rewiring that increases the likelihood of having synchronized activity of the brain, and that synchronized activity can then drive and take over the rest of the brain. It's sort of like at a party, if there's one person who's particularly loud and obnoxious and yelling, the rest of the party is not going to be able to communicate and talk and engage in normal conversation, and they're actually going to turn and pay attention to that particularly disruptive area and focus. So this area of the brain actually drives and synchronizes other areas of the brain transiently to cause the seizure. So in focal epilepsy, this small pathologic area episodically propagates. So it doesn't happen all the time, but even in the most severe epilepsy, seizures are only 1% of the time, is quite a bit and disruptive of patient. And so to be cause significant health problems, episodic disruption of normal brain function can be quite debilitating. There are two primary pathways that are implicated in propagation. First is the circuit of Papes, which goes through the hippocampus. This is known as a limbic circuit, and it tends to be slow. Propagation is slow through this circuit. So seizures will tend to evolve more slowly. You may have an aura, because it's so slow, there may be a chance that before it spreads, that the seizure will abort. So you may have what's called an aura in isolation before it spreads to a loss of awareness or to a generalized tonic-clonic seizure. More faster pathway for propagation is via the thalamus and cortical thalamus interconnections, and this is associated with primary generalized. So the thalamus is a dense nucleus at the center of the brain, and it projects broadly to the rest of the brain. And so if seizures propagate here, it's a relay station that can rapidly propagate that pathologic activity to other areas of the brain. So this is an example of how an acute injury can progress to cause those hippocampal changes that lead to mesial sclerosis. This is a 2-year-old patient who had prolonged febrile seizures, and you can see that there's a signal change here on the right hippocampus compared to the left. This bright increased intensity, and then 9 months later, you can see that there's significant atrophy on the right compared to the left, associated with risk for epilepsy. And this is a schematic of the two pathways with the circuit of Papez. Here's the hippocampus. This projects to the mammillary bodies, the anterior nucleus of the thalamus, the cingulate, back down the entorhinal cortex, and forms a loop. And seizures starting in the hippocampus can propagate relatively slowly. And one of the ideas with some of the new treatments, in particular deep brain stimulation anterior thalamic nucleus, is that by stimulating here, we can block that propagation and prevent, we may not necessarily decrease the frequency of seizures in the hippocampus, we can prevent the disabling effects of propagation through other areas of the brain. This is a thalamocortical circuit. So the deep thalamus projects, the thalamic relay nucleus projects to the cortex, and that happens all over the brain. So you have a rapid propagation, and it's harder to intervene to stop the propagation. So most of the therapy is geared towards preventing abnormal firing in the first place. So what is a recommended evaluation when we suspect this is a seizure and have a high suspicion for epilepsy? So initially, if we see a patient acutely, we order labs to look for metabolic derangements that may indicate a provoked seizure that might not need to be treated. Imaging is key to rule out serious infections or tumors or vascular malformations. And unless you have an EEG beforehand, if the EEG clearly shows a primary generalized epilepsy, then you don't need to have a brain image. But otherwise, we especially if we don't have all that information, we will order an image in the emergency room. If there's a patient is not back to baseline, we'll worry about an infection, and herpes would be one. And so we may do a lumbar puncture. An EEG is another key study. Again, if the patient returns to baseline after the imaging, you may be able to do the EEG as an outpatient. So some of this workup can be adjusted, but as I mentioned earlier, the EEG can be informative in the acute period. Even after the seizure, you may see post-ictal depression. Won't get into too many of these, but there are other specialized studies that we can do. These tend to be more in patients who don't respond to medication treatment. And then in the elderly, I mentioned that vascular disease, is a consideration. So I may look in the vessels, the neck and brain in elderly patients who have a new onset seizure. And then young patients, obviously genetics for those idiopathic or primary generalized seizures is a consideration. So the EEG we use to characterize the activity, I mentioned that there's an abnormal area that is very synchronizing, and that synchronization can disrupt. It's pathologic, it can disrupt. And so the EEG, we place different electrodes over the surface of the brain, and we can localize if there's a synchronizing area, and create a grid to measure the activity. And then synchronizing activity, the brain, normal brain is functioning, it's behaving it's processing complex information, and synchrony prevents that processing of complex information. So the normal brain doesn't behave with synchronized firing of large populations of neurons, so you shouldn't see that in the normal brain. So the EEG is very informative, both if there are areas of synchronization, and then are they focal for these focal onset epilepsies, or do they occur in a generalized pattern all at once for the generalized types of seizures that tend to be more genetic. So focal epileptiform activity, the odd numbers here are on the left, and you can see that there's this synchronized high amplitude, what's known as a spike. So that's a synchronized firing of activity, and it's focal, so we'd be thinking of a focal epilepsy in this situation. And here is a 3 per second spike wave of absence, a primary generalized epilepsy. And so you can see this, it may be hard to read, but this is left, right, and left, right. And you can see that it's synchronized across both sides all at once. There's the fast spike, and then there's a slow wave after that. So that's a generalized epilepsy. So the EEG is very helpful in terms of diagnosis. And then other studies that, again, we tend to do if the earlier studies are uninformative or if the patient doesn't respond, are a PET scan. The MRI of the brain, which is much more sensitive than a CT scan, is good for anatomy in general. But as I indicated, it can be a very small lesion, often microscopic, that can cause an epilepsy just because that's where it starts. And you may not see that on an anatomical study like an MRI, but on a functional study that measures the metabolism of the brain, it may be quite evident. In focal epilepsies, especially temporal lobe epilepsy, 70 to 90% will show a hypometabolism. So between seizures, you will have a hypometabolism, using less energy. If you were actually able to capture a seizure, you would see a hypermetabolism. You can see on the right here side of the brain that it is much darker than on the left with the hypometabolism. And then now we can do PET MRI fusion, so we can fuse the anatomy. You can see with this MRI that the right side is smaller than the left. This structure, that the ventricle is a little bit larger, the space. So when you have larger space, that means the structure is smaller. And you can see on the PET, superimposed PET, through this cut that it's darker here. There's not as much glucose uptake, which is the tracer they use on the right compared to the left. So that's very useful to overlap those studies to clarify the area that may be triggering the seizures. And now, and we're increasingly using magnetoencephalography. The EEG really only measures the surface, so you only see activity that gets to the surface of the brain, and it measures it over the what are known as the gyri, whereas magnetoencephalography, which measures the magnetic field as opposed to the electrical field, can go much deeper into the crevices of the brain known as the sulci, and you can detect areas that might be missed on EEG. So it can be very informative as well for localization and characterization of an epilepsy. And again, we tend to do these studies in patients who don't respond to medications. So what is the best management for your patient? So if you've had a first seizure, It's important to keep in mind that epilepsy is diagnosed as two unprovoked seizures greater than 24 hours apart, or with one with high likelihood, greater than 60% of a repeat event. There are certain syndromes in children where you could have never had an epilepsy, but because of the syndrome, the features that may not be seizures but are highly associated with seizures, you may treat it as an epilepsy in those instances as well. We often don't treat a single seizure, especially if it's provoked. Once you remove the inciting trigger, you're unlikely to have a recurrence. If it's a medication, you would stop that medication and switch to another medication. It used to be that within a year that a single seizure 80% would not recur. We're finding that there's higher recurrences as we look longer out, up to 33%. So a lot of our decision after a single seizure to treat will depend on other studies such as the EEG, in particular an MRI. And if you have a first seizure with epileptiform activity on the EEG, there's a 50 to 70% chance of recurrence at 1 year. So then you would be really inclined to treat with an anti-seizure medication. So choices of anti-seizure medications, this really depends on the type of epilepsy, whether it's focal versus a primary generalized. Many of the seizure medications have similar effectiveness, so we often choose a medication by the particular identifiers of the patient. If they're elderly, if they're on other medications, if they're female, there's certain medications to avoid. If they have the other medications where the seizure medication is more likely to interact and cause problems. So these are very important considerations when deciding on anti-seizure medication. And we try to balance seizure control while avoiding the toxic side effects, which can be more disabling to the patient than the seizure in many instances. And then we also consider compliance with the seizure in a particular patient. If it has a long half-life, that'll be easier for the patient to comply with. So for focal onset epilepsies, this is a long list of some of the medications. So these are for focal onset epilepsy, and then for primary generalized, this is a typical list. And then broad spectrum include these medications: valproate, lamotrigine, perampanel, levetiracetam. And so if you don't know after your initial workup what type of epilepsy it is, you might want to try a broad spectrum. If the EEG is unrevealing, if the imaging is unrevealing, but you're pretty sure maybe there have been 2 seizures, you may want to try a broad spectrum anti-seizure medication. And so anti-seizure mechanisms, generally these drugs act on ion channels: sodium, calcium, potassium, and neurons are like batteries. And when you have synchronous firing, there is sodium entry into the cells, and so drugs that decrease sodium can have anti-seizure effects, similar for calcium, and then drugs that enhance potassium, which prevents that depolarized synchronous firing, can also be beneficial, although we have very few for those. Then the other is the brain communicates via inhibitory, known as GABAergic transmission, and excitatory glutamatergic transmission. And so the idea with synchronous firing is that you have more excitatory transmission or loss of inhibitory transmission. And so some of these medications like benzodiazepines, valproate, vigabatrin, which we use more in children, tend to increase inhibition. And there are some that now decrease excitation. They're not. Topiramate is one. Perampanel is one of the newer medications that decreases excitation. So these drugs act by affecting the synchronous firing through those ion channels, or by shifting the balance of inhibition or excitation as the primary mode of action. And there are some that have unusual actions, such as levetiracetam and now brivaracetam. So the choice, there's very little great evidence that one anti-seizure medication is more effective than another. The newer ones tend to have a much better side effect profile and fewer drug-to-drug interactions, but they can be more costly, though many are now generic at this point. For consideration with female patients, valproate should probably be avoided. It can have effect on embryonic development, and often before a woman knows she's pregnant, the effects of the medication could have adverse effects. And in Europe, they actually tightly regulate the use of valproate much more than we do here in the U.S. There are other effects on weight gain and fertility that also should be considered, and it probably should be avoided unless absolutely necessary. It is one of the better medications for primary generalized epilepsy, so there may be some times when you need to use it, but in general, especially in female patients, this should be avoided. Elderly, there are some medications that will interact with their other medications or change the metabolism of other medications, or can cause toxicity quite easily if the level gets slightly high. Phenytoin is one in particular. We don't use this as much, but it probably should particularly be avoided in the elderly. We have many more alternatives now with medication choice. Lamotrigine is an activator, so that can be good in elderly patients. Carbamazepine, you have to be careful on how you start it, and there are certain patient populations that may have an immune reaction to carbamazepine. It interacts with their immune system, in particular in Asian populations. And so given that we have so many choices of seizure medications, it might be better just to think of another medication first in certain populations. So the goal of therapy is to stop seizures with minimal side effects, and you need to balance the quality of life, treat a patient, not the level. Start low and go slow. I tend to push a single anti-seizure medication to a high level before I give up and try another one. And I think it's very, very good to be systematic, so you know that a medication failed before you consider another one. I make one change at a time so that I know what the cause and effect relationship is. If I do too many things at one time, I'm not going to know which one either made things worse or better. So it's best to approach very systematically. You need to monitor for adverse effects, need to be monitored for with labs for particular medications, checking liver labs, or with valproate or carbamazepine, blood CBCs, so on, for particular medications need to be monitored. And then a seizure log is often very helpful to gauge if a medication is working or not. If you have a sense that having a very objective measure is really informative, so that we know that whether to continue with the medication or whether to switch to an alternate. So precautions, there are some medications. These tend to be the older anticonvulsants, phenytoin, carbamazepine, phenobarbital, that are enzyme inducers. Vitamin D is a steroid, and some of the steroid metabolisms happens through the liver. So if you induce those liver enzymes, you're going to affect vitamin D levels. and that it can cause an increase in alk-phos, which comes from bone, on patients who are on these enzyme-inducing medications. Can also induce metabolism of oral contraceptives, also steroids. So if a patient is on one of these, we'll supplement with vitamin D, calcium, and monitor bone density, and be very conscientious of any failure that might happen with an oral contraceptive, and be mindful of this, and avoid that anticonvulsant if indicated. Enzyme-inducing anti-seizure medications can also raise cholesterol, and so this may need to be followed as well. And then, as I mentioned, in a young woman of maternal age, there are teratogenic effects from anticonvulsant, in particular valproate. And so many of these effects can happen before a woman knows she's pregnant. So I do folate supplementation in female patients, and even male patients who are on medications that may be prone to lower folate, because folate has effects on cerebellum and so on. So if you try a seizure medication, the first medication will be associated with seizure freedom about 47% of the time. Then if you add or switch to a second drug, you'll get another 13% of patients who will be seizure free. And that brings you up to 60%. But after that, a third or more, you really have a minimal benefit. So roughly, we can control around 2/3 of patients with anti-seizure medications, but that leaves a significant number, a third or more, 30 to 40%, who do not respond to medications, and really the quality of life is very dependent on seizure freedom. So this is an argument to really start to consider alternative treatments for epilepsy. And we don't stop continuing to look for a medication to improve. There are patients who will respond remarkably well to a particular medication. And so we keep looking, but we also should early in the course, after failure of 2 medications, start to consider alternate therapies. And so these include, let's see. These include surgery, in particular anterior temporal lobectomy. There's also laser ablation. There was an early resection of surgery that showed that within 2 years of diagnosis, many patients, prior to that, the average time for being referred to a comprehensive epilepsy center was 20 years. So a patient has had epilepsy for quite a bit of time that it's been refractory, and there are significant adverse accumulation of impacts on your life at that point. And so early evaluation by a comprehensive epilepsy center after failure of 2 medications is the key to maintaining a quality of life rather than waiting 20 years. There is now selective amygdalohippocampeectomy, is a very circumscribed resection in the appropriate patient that can minimize any adverse consequences from surgery that may occur with resection involving larger areas of the temporal lobe. We have other interventions like vagal nerve stimulation that has been around for many years now, where the left vagal nerve is stimulated, and this can have an effect that improves over the first 6 months to a year, and can significantly decrease the frequency and severity of seizures. There are newer treatments such as responsive neurostimulation, where you can put an electrode in an area of the brain that is that seizure onset zone, that synchronized pathologic area that episodically recruits the rest of the brain to have a seizure. And the electrodes in the appropriate area can detect the onset of that seizure, and then they'll deliver a shock to stop that seizure. Deep brain stimulation was recently approved 2 to 3 years ago for the anterior nucleus of the thalamus. There are other in Europe. They actually use it in the hippocampus, and in the U.S. we're actually stimulating other areas of the thalamus as well. We don't have enough data on those, but those are all. There are going to be many more options for deep brain stimulation in the future. And so this is the responsive neurostimulation, and we have to have an idea of where you can either place a depth electrode deep in the brain, say in the mesial temporal lobe structures, the hippocampus, or if the focus is more on the surface of the brain, you can put a cortical strip over the surface. You can have 2 electrodes or a strip and electrode per device. They're working on newer devices that will have options for 4 leads that will increase the versatility. And again, this is an attempt to abort a seizure before it can spread and cause greater disruption and problems. Deep brain stimulation is in the nucleus of the thalamus. Remember, that was along that circuit of Papes, which is a propagating pathway of seizures. So this is, in a sense, to set up a roadblock for that propagation. And then just briefly, some other aspects. There are many other considerations besides control of the seizures, and some of them are more important to the patient. So just briefly to go over these so that patients are aware to be mindful of these and bring them up with their doctors. One is that depression is very common in epilepsy, even more so than other severe disorders like diabetes, asthma, COPD. 29%, some estimates as high as 50% of patients can have some form of depression, and it seems to be much more common with temporal lobe epilepsy. And there are many reasons for this. One, I think there's good evidence that certainly in research that part of the epilepsy contributes to chemical changes in the brain, in particular impacting serotonin, that can relate to depression. But then there's all the psychosocial effects of seizures, not being able to drive, social stigma, worrying when you're going to have your next seizure, lack of control in your life, job restrictions. So it really can be very disabling, and the quality of life relates to the depression and some of the toxicity of medications more so than the exact frequency of seizures. And then another consideration is sudden unexpected death of epilepsy. It tends to be more prominent in patients who have generalized tonic-clonic seizures. It's roughly 1.16 patient per 1,000 patients per year. One of the celebrity standouts who likely experienced this was the track star Florence Griffith Joyner, who had a seizure during sleep. Often a patient will be found in the prone position after the seizure, and most of these happen at night. There are some ideas as to the mechanism. One is that epilepsy can impair, both in the acute postictal period, can impair the breathing drive of cells in the brainstem, these pacemaker cells that arouse you if the oxygen levels drop or the carbon dioxide levels rise. And if these are impaired, you don't get aroused, or if you can't arouse sufficiently because you're in the postictal state, then you cannot exhibit these self-protective mechanisms to turn and to get your head out of the pillow. That's one idea. And the other is that there is also found to be autonomic effects of epilepsy over many years that can affect the heart and the autonomic regulation, and it's potential that there may be some heart arrhythmias triggered by epilepsy as well. So this is something that you should be aware of, that if a patient is having nocturnal seizures, particularly generalized tonic-clonic seizures, you may want to be able to monitor the patient if they have one at night, sort of an alarm or some sort of measure that maybe check in and turn the patient if appropriate. It's a small annual incidence, but over many years it accumulates. So in the best prevention against this is really to control the epilepsy and particularly get the generalized tonic-clonic seizures controlled. So in conclusion, I hope that you've learned that there are seizure look-alikes that we should be aware of, and some of the key ways of telling the pattern or features of the look-alikes from what a normal seizure looks like. I went over some of those. Many of them can be discerned by the history, and if a video is provided, that can be extremely helpful as well. Hopefully you understand some of the basic seizure types, the focal versus generalized, primary generalized, and the classifications, and understand the principles and approach to managing epilepsy and the choice of an appropriate anti-seizure medication, and are aware of some of the new alternate therapies that can have dramatic improvements and importantly add another option for patients. That there's 1/3 of patients who don't respond sufficiently to medications. And then finally, be aware of some of these other what are known as comorbidities of epilepsy. Not all the problems of epilepsy are the seizures. So on that note, I thank you, and if there are any questions, please feel free to ask.
Thank you, Dr. Naylor. If there are any questions, feel free to unmute yourself and ask directly, or you can also type your questions into the chat box. So we'll give folks a few minutes. Okay, thank you, Dr. Naylor.
Okay.
Looks like there are no questions. Thanks for your time and the wonderful overview.
Okay, I'll stop sharing then.